I'm Dr. Asim Javed. I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning process for performing mechanical thrombectomies in acute ischemic stroke. NIHSS stroke scale. This is to determine the exact severity of stroke. So you give points for every neurological deficit that the patient has. So a stroke severity of 1 to 4 means minor stroke, 5 to 15 is moderate stroke, and 21 and above is severe stroke. The other one is modified Rankin scale. That is to see how functionally independent the patient is. Especially important to know the point at which the patient comes to you with stroke, what was the exact functional status before the stroke occurred. So, for example, MRS score of 0 to 2 means patient is functionally independent. The other is aspect score. This is done on plain CT brain. This is for the anterior circulation and especially MCA territory. So what you do is there are 10 areas as shown here. You give 1 point for each area if there is a deficit there. If there is a hypoattenuated or a hypodense area, you give it 1 point. So the total score is 10. If there is no deficit at all in any of these areas, the patient gets a score of 10. And then if you see hypodensity in any of these areas, you subtract 1 point from that 10. So anything above 6 is associated with better outcome after thrombolysis, and a score of less than 6 means poor outcome and high risk of death and hemorrhage. Now, in stroke, you start off with a plain CT brain, then you go on to a CT angiogram and CT perfusion, and MRI for posterior circulation if more than 6 hours have passed. Now, in a plain CT brain, you make sure there is no intracerebral bleed. You do the aspect scoring that I just explained, and there is a dense MCA sign, which I will explain later. In the CT angiogram, you are looking for large vessel occlusions, and you do not need to wait for any serum creatinine renal function tests to establish renal impairment. You just need to go ahead with your CT angiogram. No need for doing the RFTs. Now, in this is CT perfusion. So the objective of CT perfusion is to assess the tissue capillary level perfusion. Ischemic penumbra, that represents salvageable brain. That is the part of the brain which may be ischemic but not infarcted as yet. Now you've got cerebral blood flow, that is measured as ml per 100 gram of tissue per minute, and cerebral blood volume, which is measured as total amount of blood in that part of the brain, ml per 100 gram of tissue. In case of obstruction, a large vessel occlusion, the cerebral blood flow is reduced. Transit time is the time taken by the blood to enter the brain and come out from the venous side, typically 3 to 4 seconds. So cerebral blood flow in ischemic core is around 10 to 15 ml per 100 gram per minute, and this is the level where there is irreversible brain cell damage or it is dead. So that is core. But the penumbra or the ischemic zone is around the blood flow is around 15 to 35 ml per 100 gram per minute. This is the symptomatic brain which is dying but still salvageable. So not to worry about these numbers, because these numbers are calculated by the machine itself. So if you look at this here, this is the TTP, it's written over here, this is time to peak. So you can see that there is a red deficit that comes up on this side. That means this part of the brain has a deficit. It has a perfusion problem here, and blood takes a lot of time, prolonged time, to go from the arterial to the venous side. Now we have to look at the cerebral blood volume, and that's the cerebral blood flow. So we want to see if there is a corresponding deficit in this area as well. But here you can see that the perfusion is equal on all sides. That means there is no delay in this, there is no problem on the cerebral blood flow. So there is a mismatch of defect. The defect that you see here in the TTP is not seen here in cerebral blood flow. That is called a mismatch, and that means this area of the brain which is at risk, this is penumbra, and this is a salvageable area. On the other hand, if there was a defect seen in this area as well as seen here, this defect would have meant a matched defect between the TTP and the cerebral blood flow, and that would have meant a core. That would have been infarct, and that brain area could not be salvaged. So what we do is the algorithm that we follow in RIC is that the patient arrives in hospital or has a suspected stroke. A plain CT brain is done immediately, and our door to CT time as per guidelines is 20 minutes. The next thing, you need to rule out cerebral bleed, and then if the clinical scenario is appropriate and there's no bleed, then that patient has ischemic stroke, and we consider the patient for thrombolysis, and our door to needle time has to be 60 minutes. That is the goal for starting thrombolysis. The next thing, while the thrombolysis decision has been taken, you do not stop here. You go on to CT angiogram and you want to rule out a large vessel occlusion. If there is a large vessel occlusion, you move that patient to the cath lab and the groin puncture needs to be done within 90 minutes. So the three goals are door to CT time of 20 minutes, door to needle time of 60 minutes, and door to groin puncture time of 90 minutes. Now, patients that are eligible for IVL teplase should receive IVL teplase even if mechanical thrombectomy is being considered. This is class 1A indication. So if a patient qualifies for mechanical thrombectomy, it does not mean that the patient cannot receive IVL teplase now. If he qualifies for both, he gets TPA, and you do not wait for the TPA to finish. You do not wait for that result to see the improvement. You start the TPA infusion and you take the patient to the cath lab and you do the mechanical thrombectomy with the TPA going on. Now, in patients under consideration for mechanical thrombectomy, observation after IVL teplase to assess for clinical response should not be performed. That's a class 3 indication, exactly what I just explained. Now, this is very important to remember. No antihypertensive should be given, no antiplatelet should be given, no anticoagulants should be given. This is very important to understand and remember. Tell your ER teams, for a patient of stroke, ischemic stroke, no antihypertensives, no antiplatelets, no anticoagulants. Antiplatelets and anticoagulants increase the chances of bleed when they are later on given TPA. Therefore, we do not give these patients these things. Antihypertensives, the role I'll explain a little later at the end of this presentation. Now, again, going into slight depth, how we follow it, and this is the exact algorithm that we follow in RIC. This is our own made algorithm based on American Heart Association and Stroke Association guidelines. So, patient arrives at the ER, we note down his last seen well time, we check his vital signs, his blood sugar, NIHSS severity is determined, and then we do a plain CT brain. If there is any bleed on this, we refer the patient to a neuro center. If there is no bleed and the clinical scenario fits in for a stroke, then it means this is ischemic stroke. Now comes the first time window, which is within 3 hours of symptom onset. This is the first time window. Now, age is more than 18 years, there are severe symptoms or mild but disabling stroke and no contraindications to thrombolysis, then the patient gets IVL teplase. Now, what do we mean by severe symptoms? Understood, but then there is or mild but disabling stroke. So mild stroke means there is no power deficit at all. So the NIHSS stroke scale, the severity will be very low. It's a mild stroke. If the patient has aphasia and no power deficit loss at all, but then having aphasia is a big disability. So these are the patients who will still fall in this window where you have aphasia, no power deficit, so it's a mild stroke, but it's a disabling stroke. The patient will still qualify for IVL teplase if he is within 3 hours of symptom onset. Now, what about if the patient arrives within 3 to 4.5 hours of symptom onset? So he's beyond 3 hours, but still within 4.5 hours of symptom onset. So if the patient meets the criteria that has been described in the first category of within 3 hours, then in addition, age should be less than 80 years, NIHSS stroke scale should be less than 25, and he should not be on warfarin, and the ischemic injury should not be more than 1/3 of the MC territory on the CT brain. In that case, this patient can still be thrombolyzed. So now we understand that these are 2019 guidelines of American Heart Association that up to 4.5 hours of symptom onset, patient can still qualify for IVL teplase. And the dose would be 0.9 milligrams per kg over 60 minutes. Maximum dose is 90 milligrams, and the first bolus dose of 10% is given as IV bolus over 1 minute. After 4.5 hours of symptom onset, there is no thrombolysis. So what we do practically in RIC, we do the plain CT brain and we assess the CT brain, and if the patient qualifies for L teplase, the nurse gives the bolus of alteplase there and then on the CT table, and then the patient undergoes a CT angiogram, and the nurse in the meantime prepares the alteplase infusion. So the CT angiogram, the moment it is finished, the nurse comes and connects the IV alteplase infusion, and the alteplase infusion starts. And if there is a large vessel occlusion, we will move the patient to the cath lab with an ongoing drip of alteplase. Now, after CT brain, so there's one more caveat to it, that if the patient has had a low molecular weight heparin within the previous 24 hours, then of course IV alteplase is out. You cannot thrombolyze that patient, he will bleed. Now, after CT brain and after the IV alteplase issue has been finished, the patient is on the CT table undergoing a CT angiogram. What you are interested in is the anterior circulation stroke or the posterior circulation stroke. So in the anterior circulation stroke, it will either be an internal carotid or an MC occlusion, that is the large vessel occlusion, or the posterior circulation stroke where there will be a vertebral or basilar occlusion. Now, if it's an anterior circulation stroke, now comes the second time window that you need to consider. If the symptom onset to groin puncture can be done within 6 hours of symptom onset, age is more than 18 years, pre-stroke MRS is 0 to 1, which means functionally he was very independent before this stroke occurred. NIHSS stroke scale is more than 6, which means it is more than mild stroke. Aspect score is more than 6, which means that on the CT brain, there are not many hypodensities seen already established there. Then this patient qualifies for mechanical thrombectomy, and this is a class 1A indication. Now, if the symptom onset to groin puncture can be done within 6 hours, but the pre-stroke MRS score is more than 1, NIHSS stroke scale is less than 6, aspect score is less than 6, ICA but it is still an ICA or M1 occlusion, then this patient still qualifies for mechanical thrombectomy, but it is level of evidence E class 2B indication. Now, what about those patients who reach within 6 to 24 hours of symptom onset? If the groin puncture can be done within this time period, it is beyond 6 hours now, so you cannot rely on the CT brain alone. Now you have to do a CT perfusion, and there are certain criteria that need to be met, and then this patient can still qualify for mechanical thrombectomy based on Dawn and Diffuse 3 trials. But for this, remember, CT perfusion is a must, and you have to see that perfusion mismatch that I just explained. Now, if the patient has a posterior circulation stroke, which is vertebral or basilar, and the symptom onset to groin puncture can be done within 6 hours, then the patient can straight away go for mechanical thrombectomy. But if the posterior circulation stroke, the groin puncture cannot be done within the first 6 hours of symptom onset, then from 6 hours to 24 hours you need to take the patient for an MRI of the brain. CT perfusion is not done for the posterior circulation. You need to do an MRI, and you have to see the diffusion flare mismatch, and then the patient can still qualify for mechanical thrombectomy if you see viability there. Now, based on all of this, what I just explained, this is a figure that we've made ourselves for RIC, and this is based on American Heart Association 2018-19 guidelines, and this is an algorithm that we exactly follow, and the same algorithm we've displayed in the form of boards and charts in our ER and CCU and all the important areas and CT department and cath lab. Again, we've made these pages which are in the printed form available in the ER with all the scoring systems on them, and this is our audit collection, this data collection form which is filled up for every patient. It's the same algorithm that we follow. It moves with the patient file everywhere he goes, and this algorithm is followed. So what we've done in RIC is that we've made an acute stroke team WhatsApp group on which we've got all the ER physicians, the interventional cardiologists, our neurologists, our radiologists, then the CT technicians and our cath lab nurses. And what we do is every patient who reaches the ER, once his initial notes are jotted down, his ER arrival time comes on the group, and his initial notes of the first physician, first medical contact are displayed on this group, and then the CT brain, the moment it is done, it is shared by our CT technicians on the group, and the stroke team on call is alerted that there is a case uploaded on the WhatsApp group. They will review the CT on the WhatsApp, especially if it is after working hours when everybody has gone home, and the on-call team also works from home at present. So they will decide on the CT brain if the patient qualifies for TP or not, and then they will write down the message, and the ER team will calculate all the NHSS and all those scoring systems, and they will check for contraindications. And then once they give TPA bolus, that bolus time will also be noted down here. And then similarly, CT angiogram will be done, and all the live images will be shared here. And based on that, whether there's an LVO or not, that decision will be taken. And if the patient is to be shifted to cath lab, then the cath lab nurses will note down here the time of arrival in the cath lab. They will note down the groin puncture time, the recanalization time. And then what we do is, based on all of these cases, every day in the morning at 8:15, a 24-hour audit is presented. In our morning meeting, it is presented not only for stroke but for primary PCI also for the last 24 hours and all the mortality of the last 24 hours. We discuss all of these things in the beginning of the day, so that we exactly know what happened in the last 24 hours. So like these, the 20 stroke codes were conducted on 11th December 2021, which I've just presented here. And then we calculate everything. Door to CT time was delayed in 6 cases, and then 9 patients had presented within 4.5 hours of symptom onset. Then you can see here that door to needle time was 52 minutes, 1 patient was thrombolyzed, 2 patients underwent mechanical thrombectomy, 1 had a door to needle groin puncture time of 88 minutes, 1 had 1 of 5 minutes. And then we discussed all the reasons why the patients could not qualify, why there was a delay in the CT. Everything is discussed here. So just going to take you through one of the cases. So this was a 74-year-old gentleman with paroxysmal atrial fibrillation, 1 hour history of stroke, left hemiplegia, pre-stroke MRS 0, which means he was functionally independent, ER MRS 5, which means he's on the bed, doesn't understand, and totally dependent. NHSS 17 means he's got quite a severe stroke. So first thing to be done, CT brain. And if you look at the still image here, CT brain, you can see that's a dense MCA sign here. So this is that you can see and see the MCA even without giving contrast in it. So this is a thrombosed MCA. Now, and there is no bleed on it. So this patient qualifies for LTEPLAs because this is 1 hour history. So after this, we do a CT angiogram, and these are all the axial, coronal, and sagittal sections, and you can see a blocked right MCA and right ICA here. So you can see on CT axial, that's where the right MCA is blocked, that's where the right MCA, and this is where the right internal carotid is blocked, just at the point of its bifurcation into ACA and MCA, called ICA terminus. And then you can also see that it's actually blocked here as well. This is just after the origin, and this is on the angiogram, pre-thrombectomy, MCA blocked here. That's the stent retriever that was used to take the clot out, and that's the post-thrombectomy. You can see all the blood vessels are back. Quickly, 36-year-old lady, doctor's wife, severe mitral stenosis and atrial fibrillation are everyday cases that we see. 1 hour history of aphasia and right-sided dense hemiplegia, and she had a complete ICO occlusion. You can see empty brain skull on the left, on the lateral view, and that's the point that you can see here. And then aspiration was done for her, no stent retriever used. That's the amount of clot burden that came out, and beautifully the whole circulation is opened up. So now this is the lady just before intervention. You can see she's hardly able to move her limbs, and now this is the lady maybe this is 2 hours after thrombectomy in CCU. She's sitting up, she can move her arm, she can move her leg, and I think 2 or 3 days later she was discharged home. So this is a 31-year-old lady, came in with prosthetic mitral valve and 9 weeks pregnant and 4 hours history of left hemiplegia. You can imagine how critical everything was. So there you can see that the ICA is blocked, and that's the stent retriever that came out with this material. Everything opened up, and this is, I think, immediately a little while after the thrombectomy, and you can see that she can move both the limbs, upper and lower. So this intervention really gives you miraculous results, provided the patient comes in time and you're able to help her out. Now, 2021, we've got the latest European Stroke Organization guidelines, and according to them, If the blood pressure is more than 185 over 110 and does not come down despite of your treatment, then you cannot thrombolyze the patient. Similarly, if the patient has been on dual antiplatelet therapy prior to stroke, that does not mean that you cannot give alteplase. You can still give alteplase, but if you're giving alteplase to the patient, what is important is that you do not give antithrombotics within the next 24 hours. So if the previously a patient was on dual antiplatelets or single antiplatelet, that's not an issue. You can still give thrombolysis. But if you give thrombolysis, then in the next 24 hours, you do not want to give any more antithrombotics. There are certain exceptions to the rule, which we will see once we talk about intervention. And especially when we talk about angioplasty in atherosclerotic stenotic disease in the brain. Then what is important, over 80 years of age, you can still thrombolyze the patient. So what antihypertensive drugs you should use? You should use the short acting ones. And what we have available to us is labetalol. So we can give boluses of 10 milligram and we can repeat up to one time. And then if you still need something more, you can give IV labetalol infusion. You've got nicardipine, but I am not sure if it's available to you. It's not available to us, at least in RIC. Then it's important to know that if the patient has used NOACs in the last 48 hours, or his platelet count is less than 100 into 10 per 9 per liter, or if he's on warfarin and his INR values are more than 1.7, then he's not a candidate for thrombolysis. Aortic dissection and infective endocarditis, you cannot thrombolyze these patients. Now, these are different scoring systems to predict which patients can go on to have symptomatic intracranial hemorrhage. So you can use any of these scoring systems. Again, latest European guidelines, according to them, keeping blood pressure below 180 over 105 during and 24 hours after mechanical thrombectomy, that's their recommendation. So you need to keep it below 180 over 105 after mechanical thrombectomy, during and after mechanical thrombectomy. And then again, what they recommend is that during the first 24 hours following successful mechanical thrombectomy, they do not recommend taking blood pressure below 130 millimeters of mercury. So that's important. And then they want you to avoid large systolic pressure drops for these patients. So why is so much talk about the blood pressure? So what's in initial talk, I told you that it's important that you tell your ER physicians not to drop the patient's blood pressure when he presents with ischemic stroke. Why? Because you see, these are collaterals that have been recruited, because of which the area is still salvageable, what we call as penumbra, and the core is still small because there's a lot of collaterals there. And how do you maintain these collaterals and how do you recruit these collaterals? So there is a process of auto-regulation through which body raises the blood pressure so that the collaterals can be recruited in. But if you give a sudden drop to that blood pressure or a massive drop, these collaterals will vanish and the infarct is going to really increase in size like this. Excuse me. Now, here you can see a patient who has poor collaterals and a patient who has really good collaterals. Both have occluded MCAs here, but this one has good collaterals and we call them slow progressors, and they give you more time to recanalize before the brain actually dies. And this patient is a fast progressor. He's got a blocked MCA and there are no collaterals here. These are fast progressors and they give you very little time to recanalize and the damage is very quick. So you can see these are follow-up CTs for this same mechanical thrombectomy result, but different outcomes for poor collaterals and good collaterals. So that's very important to understand. Thank you.